Hello, friends. So today I'll be talking on this new topic, checkpoint inhibitor pneumonitis. So this is a relatively new topic for possibly most of the intensivists. So I wish to acknowledge my colleague, Dr. Amrita, who helped me uh, prepare this content. So now with possibly onco-intensive care patients increasing in ICU, so it is very important that every intensivist is aware of certain distinctive pathologies that are seen in onco-intensive care patients, and this is seldom deliberated upon by many of us. So this is a sort of an entity or a nomenclature which I believe every intensivist should know because there are new drugs. There are a lot of new drugs that are being used in cancer patients. And one of the important domain of drugs that are being used is immunotherapy. And there are a lot of new drugs that are being used. And new drugs come with new set of problems and side effects. And checkpoint inhibitor pneumonitis is one of these distinctive side effects of the drugs that are used in cancer patients. So that is the background. So, and it is important for us to understand the nitty-gritties of these pathologies. Um, so when you talk about checkpoint inhibitors, so there are various drugs. So as you see, these T cells expresses certain receptors. So the main receptor which is incriminated is these T cell receptors and the programmed cell death receptor, PD-1. So there are certain drugs which act on two distinctive sort of receptors. One is programmed death receptor, and then there is programmed death ligand, PDL1. So the drugs that act on PD-1 receptors are nivolumab and pembrolizumab. So these are all come under the domain of immunotherapy. Then there are these tumor cells which sort of manifest this programmed cell death ligand 1. And there are certain drugs which distinctly act on this programmed cell death ligand 1. And these are some of the drugs which again come under the class of immunotherapy, which is atezolizumab, avelumab, and durvalumab. So all this immunotherapy, which I'm sure many of the intensivist trainees would be listening for first time, these are used in various types of cancer. It's not like these drugs are specific to certain cancers. They come under the armamentarium of immunotherapy and they're interchangeably used in many of the cancers. So basically, the receptor and the ones that these drugs act on programmed death receptor PD-1 and PD ligand 1. So if you remember these two, many of these drugs tend to act on this. Then there is another group of drugs which is ipilimumab, which acts on cytotoxic T lymphocyte CTLA4 receptor. So this is another group. So these are the main two groups. One group acts predominantly on the programmed death receptor and PDL1. And there's another group which acts on cytotoxic T lymphocyte antigen, so which is ipilimumab. So the way they act is, so basically they block the binding of these, they basically act and prevent the binding of these receptors with PDL1 and PD1. By doing this, it tends to activate the lymphocytes. So the lymphocytes get very activated. So the lymphocytes get, so if the immune therapy, the whole concept is activating these lymphocytes to express a lot of these receptors to counter the cancer cells. by activating these lymphocytes, the cytotoxic function of these lymphocytes increases and they act against the tumor cell replication. So this is how pretty much they act, and it prevents the apoptosis, or the programmed cell death is mitigated by activating these lymphocytes by preventing the binding of these PD1 receptor to PDL1 ligand. So that is in summary the way this immunotherapy acts. Basically, it activates the immune function, activates the lymphocytes, and these lymphocytes attack these tumor cells and prevent the apoptosis of these cells. So this is in essence how this immunotherapy acts. So if you look at this table, so all these drugs which I mentioned, the immunotherapy drugs, as I said, they are used interchangeably in various types of cancers. And as you see, all these act on the programmed cell death receptor and PDL1 ligand. And you can see all types of cancers mentioned here. And these drugs are used in various combinations against these cancers. So we will not dwell into this. So all these drugs have a potential to cause something called checkpoint inhibitor pneumonitis, because all these drugs are put under the nomenclature of checkpoint inhibitor. So any patients where these immunotherapy is used or any of these drugs are used, it can affect the lungs. So that is called pneumonitis. And the way we recognize them is any patient who develops new respiratory symptoms with radiological findings of different nature, which we will talk about in detail. One should suspect the one of the cause may be this checkpoint inhibitor pneumonitis. But the whole problem with oncology patients is when you have a CT or X-ray showing all these changes with respiratory symptoms, almost always there are other differentials that exist, and we need to absolutely rule out the infection because most of these oncology patients will be in an immunocompromised situation. The risk of infection is very high. That is the first one. The second one is they may have this underlying tumor itself, which may be progressive. So the tumor progression also has to be ruled out. And the incidence of this checkpoint inhibitor pneumonitis caused by these immunotherapy agents are 3 to 5%. So it's not very much, but not very uncommon as well. And the other word they use is immune-related adverse events. So this was a big series that was done in 18,353 patients where they were put on various immunotherapies, and they found that the mortality, the attributable mortality was only 0.45% due to the side effects of this immunotherapy. But when someone develops checkpoint inhibitor pneumonitis, the mortality can go up to 28% because 23 out of 82 died, which means pneumonitis is a bad thing. So any of these cancer patients who come to ICU, historically, if you find out if they have received any of this immunotherapy and lung is affected, so the whole purpose of this talk is please keep this as a differential that these drugs may have caused pneumonitis also, in addition to all other possible differentials that you would have ruled out, which is infection, tumor progression, and so on and so forth, which we'll talk in the next slide. So with regards to cytotoxic T lymphocyte antigen sort of agent, CTLA4, what we call, the immune-related adverse events can occur up to 90%. And when you're using PD, programmed cell death receptor, or PDL1 ligand agents, the immune-related adverse events is 70%, which means most of these therapies which are used in cancer patients, which is CTLA4 or PD1, PDL1, all these have an ability to cause immune-related adverse events but of varying degrees. Some of them may be very mild, may not be noticeable, but some of them, if they develop pneumonitis, it can be severe, it can be lethal because 28% is the sort of a mortality that can happen with pneumonitis. This is something intensive care trainees need to be aware when you're dealing with onco-intensive care patients. And these immune-related adverse events it can occur at any phase of usage. It can occur at the time of induction or less than 2 weeks to up to 1 year. So which means to say, any of these patients who are exposed to these drugs, the adverse events can develop from anywhere from the induction phase. When you have used up to 1 year, they can manifest with side effects. So this is something which you need to understand. So this is just I put in a pictorial format of all the side effects. So basically, the intensive care trainees, you must be listening. These drugs are new to us. We don't use this very often in our ICU. So it is important to recognize all this immunotherapy can cause multiple side effects involving every organ in the human body. So I've just put it from head to toe. From the head, any of these immunotherapy agents can cause neuropathy. They can cause Guillain-Barré syndrome, myasthenia, or demyelinating disease. In the eye, they can cause uveitis and iritis. In endocrine, they can cause hypothyroidism, hyperthyroidism, adrenal insufficiency, hypophysitis, and they can inflame any of the organs in the body. So this is something I want every intensive care trainee to appreciate. All this immunotherapy come with the set of side effects which can affect any organ in the body. And in that, if it affects the lung, it can be dreadful because it can cause ILD. Per se, they can cause ILD, they can cause pneumonitis, they can cause hepatitis, and they can cause myocarditis and cardiomyopathy. They can cause GI disturbance. They can cause arthritis. They can cause colitis. They can cause nephritis. Basically, any organ in the body, they can induce inflammation because of hyperactivation of the immune system. All these inflammations can happen, and skin changes. They can cause dermatitis, erythema multiforme, vitiligo, alopecia. Basically, like any cancer therapy, they can affect multiple organs. So this is something which I want everyone to understand. So what are the risk factors for checkpoint inhibitor pneumonitis? So which means there are certain group of patients who are at a higher risk of these side effects. So the gender is something that can have a bearing, and old age. So older people are at much higher risk of having these side effects of immune therapy. And someone with a history of smoking have a higher risk of getting affected, or someone who is receiving radiotherapy are at a much higher risk of developing pneumonitis. Checkpoint inhibitor pneumonitis is much higher in smokers, older age, or someone with who are undergoing radiation, or in someone who have underlying lung diseases like ILD or COPD. They are at a much higher risk of having this pneumonitis. So this is something which we need to bear in mind when we are identifying patient where we are instituting this immunotherapy. And there are grades of checkpoint inhibitor pneumonitis, and we know grade 1 to grade 4 are the grades, but grade 3 to grade 4 is more severe checkpoint inhibitor pneumonitis, and it is shown that pembrolizumab, which is a very common checkpoint inhibitor that is used for immunotherapy, has a higher risk of causing pneumonitis as compared to other PD-1, PD-L1 inhibitors, which is 3.25%. So this is good for intensivists to know that there are certain agents which have a higher propensity to cause pneumonitis compared to others. So this is something which is important to note. And if these PD-1, PD-L1 are used in combination with CTLA4, cytotoxic T lymphocyte antigen 1, the risk of pneumonitis is much higher. So this is so when you are using combination, the risk can be much higher, is something one needs to appreciate. But with only CTLA4, the pneumonitis is found to be minimal. And the duration of onset, I said it can occur from the induction up to 1 year. So 9 days to 19 months, anytime the side effects can occur. But the median duration when the pneumonitis is found to happen is 2.8 months. So that is the time frame when the pneumonitis tend to occur. So when you talk about clinical manifestations, patients will typically develop with low-grade fever, cough, malaise, and short of breath. They can have fever. And on examination, typically they'll have Velcro crackles. They'll have a lot of crackles like ILD. So it presents like interstitial lung disease. The onset can be acute or subacute. It can be chronic or it can be occult. So it can have a very smoldering chronicity to the course, or it may present with acute sort of a presentation, or it can be occult, which means you may not even recognize in grade 1 to grade 2, patients may not even get to know that they have had pneumonitis. Labs, there can be, because there is inflammatory process affecting, it is pneumonitis or hepatitis. So there is inflammation, total count will be high, CRP and ESR will be high, and PET scans are non-specific for this, and bronchoscope with the transbronchial biopsy can show the pathognomonic features of pneumonitis of varying degrees. So this is an important slide I want intensivists to know. So any cancer patients comes to ICU with short of breath, there are certain differentials that you need to run in your mind, because pneumonitis can be only said once the infection is ruled out or other underlying sort of a problems that can occur in cancer are ruled out. So I just put in a pictorial format. Any cancer patients come to ICU with short of breath, one needs to rule out veno-occlusive disease, which is very common in cancer because it's a huge, any malignant solid organ tumor, they are highly prothrombotic. They can have a lot of veno-occlusive, they can have a lot of small microthrombi formation, occluding vessels, which can lead to VP shunt or ventilation perfusion mismatch and shunt mechanism leading to hypoxemia. So veno-occlusive disease is something you should keep as a differential. I'll tell you a mnemonic to remember this. Pulmonary edema can be common, so that needs to be removed, or pulmonary hemorrhage can happen in these patients, that needs to be ruled out. Or lymphangitis is something very common in certain cancers, especially in renal cell carcinoma or hepatocellular carcinoma, when they come with short of breath, have a differential of lymphangitis also as a background, which can be causing hypoxemia, and it is a very ominous sign when someone has a lymphangitis. Or it can be pneumonitis due to radiation injury or due to checkpoint inhibitors. So any of these drugs causing pneumonitis can be one of the differential. Or the tumor itself may have been progressing, and that itself can be one of the reason for worsening short of breath or hypoxemia. And infections, of course, and underlying of underlying disease exacerbation. If they have underlying interstitial lung disease or underlying COPD, that itself can be exacerbated. So any cancer patients, you remember this picture. obviously, one thing that intensivists are good is to look for infection. So apart from infection, they can have veno-occlusive disease, they can have tumor progression, and don't discard or discount the fact that lymphangitis may be present on the underlying malignancy, especially in certain cancers, especially RCC is highest to cause lymphangitis, hepatocellular carcinoma. So there are certain cancers, or CA breast. These are some of the cancers which are known to have lymphangitis, and pulmonary edema and hemorrhage, obviously, intensivists would look at. So one of the mnemonic I thought easy to remember is vitamin C, you can remember LE. So V is veno-occlusive, I is infection, T is tumor progression, C is checkpoint inhibitor pneumonitis. If you have your cancer patients who are on immunotherapy, remember pneumonitis due to the drugs is something that can happen. Lymphangitis L, and E for edema and pulmonary hemorrhage. So remember this with CLE. So any cancer patients comes to ICU with acute short of breath, with ground glass opacities. Obviously, you have to keep this as a checklist and rule out one by one. And the whole purpose of this talk is to make oneself aware that the drugs used for immunotherapy or chemotherapy have a potential to cause pneumonitis, and that is seldom sort of recognized by an intensivist. So it's good for them to understand that all these the new agents, immune therapy can cause pneumonitis, and even chemotherapy, some of the agents can cause dose-dependent sort of a pneumonitis. So there is a grading mechanism for grading sort of a criteria for this pneumonitis, which is determined by National Cancer Institute grading. So which is common terminology criteria of adverse events. So grade 1, they are asymptomatic. Grade 2, patients will be symptomatic, needing some drugs to alleviate their symptoms. Grade 3, pneumonitis is where they have limitation of activities of daily living, needing some oxygen supplementation. Grade 4 is obviously in ICU, we would possibly be dealing with grade 3 and grade 4. In my ICU, predominantly it will be grade 4. They'll come when they need HFNO, NIV, or possible plus or minus intubation. Grade 5 is death. So very simple sort of a grading for all these pneumonitis. So this is very interesting. When I was reviewing the literature, it was very fascinating to see that there is so many pneumonitis patterns that are recognized only due to the immunotherapy that is being given. So this was a study done by French group, Delaunay et al. So they have looked at 64 patients and they found different types of pneumonitis that tends to occur. Organizing pneumonia constituted 23%, hypersensitivity pneumonia constituted 16%, and non-specific interstitial pneumonia constituted 8%. Bronchiolitis happened in 6% of these patients. These are only due to checkpoint inhibitor pneumonitis, I'm telling you. So only drug related, only the immunotherapy related sort of a pathognomonic findings in the lung. This was another study by US, Naidu et al. 19% of them had organizing pneumonia, 7% had hypersensitivity, and cryptogenic organizing or non-specific interstitial pneumonia happened in 22. And predominantly they found ground glass opacities in 37% and unclassified in 15. So generally, the cancer patients that come to my ICU, which we have seen, ground glass is something we commonly see in these patients. So when there is a ground glass opacities, remember your differentials of with CLE, you have to rule out veno-occlusive, you have to rule out lymphangitis, you have to rule out tumor progression, you have to rule out lymphangitis, you have to rule out your pulmonary edema. So all this can cause ground glass sort of opacities, and that is something one needs to bear in mind. So organizing pneumonia, you will have features like this. You will see some ground glassing, and there is a lower lung, more sort of an affinity to lower lung involvement in organizing pneumonia. And there will be subpleural scarring. As you see, it is very close to pleura. There is subpleural scarring that happens. Then you have this reversed halo or atoll sign that you can see in organizing pneumonia. So this is some of the typical features radiologically which are seen related to different pathognomonic findings in biopsy. So this is in organizing pneumonia. And non-specific interstitial pneumonia, typically you don't have subpleural scarring. So pleura is spared here. You have symmetric ground glass opacities as you see here. And there is more of reticular pattern. Reticular shadows are seen in non-specific interstitial pneumonia. And subpleural sparing is there. But in organizing pneumonia, you had subpleural scarring and pleural involvement as well here, which you don't see in non-specific interstitial pneumonia. In hypersensitivity pneumonia is more subtle variant. where you will see some ground glass here, which is more subtle, and ground glass opacity is more involving the mid and upper zone in hypersensitivity. And you see some hyperlucent areas, which is called as air trapping. And possibly in ICU, the typical patients we see is where they have crossed all those phases of ground glass opacities or subpleural involvement. We will see possibly in ICU more like this, where they have more of crazy paving pattern and there is more of septal thickening. As you see, there is a lot of septal thickening here and more ARDS features. So in ICU, when onco patients come, we see typically more of such CTs or X-rays. And this is something which I'm sure many intensivists would recognize. And when you get an X-ray like this, obviously you need to remember all this with CLE differential. And it's easy to rule out one by one and then have in mind that many of the drugs that are being used also can cause this pattern. So the whole purpose of this to appreciate that all these immunotherapy agents and the chemotherapy agents have a propensity to cause something called pneumonitis, which you need to recognize. Bronchiolitis is very subtle. As you see, this is typical feature where you have a tree-like thing with a bud, tree on bud sort of a feature, centrilobular nodules, tree in bud, and then you'll have a feature areas of consolidation more confining to the lower lobes. So these are some of the patterns that are described only which are drug related, checkpoint inhibitor pneumonitis, where they can present with this myriad features of interstitial lung disease sort of a picture. Then this is a radiation recall is where someone is receiving radiotherapy. At the area where they're receiving radiotherapy, they can have pneumonitis, which again shows ground glass opacities and consolidation. But here it is restricted to the area where they're getting radiotherapy. So this is radiation recall. So these are some of the features. So now we need to understand there is immune checkpoint inhibitor therapy causing pneumonitis, and there is chemotherapy also agents which causes pneumonitis. So immune checkpoint inhibitor pneumonitis patients tend to have this with greater susceptibility. There is more extensive lung involvement and lower lobes are more commonly involved in immune checkpoint inhibitor pneumonitis as compared to other sort of differentials. And patients are at a higher risk of developing, and it is more of a severe grade when they develop immune checkpoint inhibitor pneumonitis. It is of higher severity and multi-organ involvement tend to happen. You can remember that human body I showed from head to toe. So when there is immune therapy, it can affect any organ in the body. So that is something one needs to keep in mind. And as I said, the chemotherapy sort of a pneumonitis tends to be more dose dependent. Immune checkpoint inhibitors or immunotherapy, they tend to happen with even one dose, they can have severe reaction, and it is not dose dependent. It can happen with the first dose or second dose, and it can happen with more fulminant way with higher severity. But chemotherapy is more of dose dependent. So the higher the dose and for longer the duration, they tend to have more chronicity component as opposed to immunotherapy where it is more to do with a extensive sort of a reaction that can manifest due to the agent that has been given at the outset itself. So that is the sort of a subtle difference between chemotherapy induced pneumonitis and the checkpoint inhibitor. It's more like a reactive sort of a injury that they can have with regards to immune checkpoint inhibitor pneumonitis. So what about the treatment remains very simple. You may break your head in trying to determine why is it that patient has hypoxemia, and then finally you come to a conclusion that it may be due to checkpoint inhibitor, but the treatment is only steroids. So American Society of Clinical Oncology, which is called ASCO, for grade 1, only holding the therapy is good enough. You don't need to treat anything. And follow-up of the CT has to be done after 3 to 4 weeks to determine if they are going into some sort of a interstitial lung disease or chronicity. Grade 2 is to hold the treatment, and glucocorticoids have to be started with the prednisolone 1 milligram per kg and tapered over 4 to 6 weeks. And empirical antibiotics is suggested until you rule out the infection with procalcitonin and the multiplex PCR, so on and so forth. And monitoring of the patient has to be done every 3 days, and some radiological follow-up has to be done to see that it is not progressing. Grade 3 is what we see in ICU, where there is more patient become hypoxemic, needing oxygen, where the drug has to be discontinued, and treatment of choice is glucocorticoid and has to be tapered over 4 to 6 weeks, and empiric antibiotics has to be considered. And grade 3 to 4, obviously they are needing oxygen, so patient has to be managed in the hospital and they need hospitalization. So the treatment of steroids is prednisolone 1 to 2 milligram per kg per day for 6 to 8 weeks. And generally, the recommendation is not to give steroids for more than 12 weeks. And if someone is receiving prednisolone, this is a very important statement. If someone is receiving steroids in these cancer patients of 20 mg for more than 6 weeks, that is the time that you can contemplate that these patients are at a risk of developing PCP, and you can consider starting treatment for PCP, obviously with diagnostic tools to be put in place to confirm the diagnosis. So what I mean to say is, in the initial phase, they are not at a risk for developing PCP unless they are on steroids of at least 20 mg for more than 6 weeks. That is when they become sort of a vulnerable or at a much higher risk of developing pneumocystis carinii. So this is a point to be made, that at the outset, when you have made a diagnosis of immune therapy related pneumonitis, they are not at a higher risk of developing PCP. So, but there are now good tests, like you can do beta D glucan to rule out PCP because it has a very good negative predictive value. If patient is bringing out sputum, you can do the staining techniques. You can do Giemsa staining. There is a video that I have done. So there are now better diagnostic tools to confirm the diagnosis of pneumocystis carinii and not necessarily jump on starting empirical pneumocystis carinii. If you are starting empirical, at least there should be a substantiation that patient with oncology who's on steroids for more than 6 weeks, they become much vulnerable for developing PCP. So the point here is that you can incorporate your diagnostic tools to confirm the diagnosis of PCP because we have better diagnostic tools now. And 70 to 80% of the time, patients respond to prednisolone and they do get better. But the risk of mortality, as I mentioned in the studies, 28%, 20 to 30% is the risk of mortality when lung gets involved due to these usage of these checkpoint inhibitor pneumonitis. So prognosis and recurrence. So this was a study by Naidu et al. In 30 patients, grade 1 and grade 2 pneumonitis, all of them recover. Grade 3, 64% of them resolved. And obviously you had the rest of them who possibly died. So the mortality attributed to pneumonitis due to immunotherapy is 28% in this particular study. And quarter of these patients tend to recur. The pneumonitis can be recur. And if you re-challenge them, if you again restart immunotherapy, 17 to 29% of them can have a recurrence of this pneumonitis. So that is the data we have from this study from Naidu et al. So there are certain modalities that are suggested for refractory checkpoint inhibitor pneumonitis, which means that you have started steroids and patient has not responded to checkpoint inhibitor, has not responded to steroids. Then IV immunoglobulins is something that is suggested at 20 grams for 3 days, or IV immunoglobulin 10 grams once a day for 5 days is something that is suggested as a salvage measure or a desperate measure. So other modalities that are suggested is glucocorticoids with tocilizumab. There was one study which showed 80% response with grade 3 to 4 immune-related adverse events. Or they've used other immunosuppressants like mycophenolate, mofetil with cyclosporin, and some studies have used infliximab with cyclophosphamide. So all these basically, even after usage of these, many of them have died. And there is one study from China which has showed pulse dose methylprednisolone 500 mg for 3 days has shown some response. But these are all sort of an anecdotal reports. There's no large body of evidence to say that these salvage measures or desperate measures have shown good mortality benefit. But these are used as a desperate measures: IV immunoglobulin, pulse methylprednisolone, infliximab with cyclophosphamide, mycophenolate, because by then patient would have deteriorated and they would be at a very high risk for all this opportunistic infection. So they're used more as a desperate measure. So the conclusions is checkpoint inhibitor pneumonitis is an entity which intensivists should know because the onco patients needing ICU admissions are increasing, and increasingly these new innovative sort of immunotherapies are being used for these patients. And this is a new set of drugs which acts on PD-1 and PD-L1 ligand or CTLA-4. So the way we diagnose is clinical examination in combination with your radiological tools and the history of usage of these drugs. And please remember, checkpoint inhibitor pneumonitis is not benign. It can be fatal and it can lead to the death of the patient. And prednisolone is the drug of choice, and it controls most of these patients. If they respond to prednisolone, as I said, 70 to 80% respond. But if they don't respond, the mortality sits at around 28%, 28 to 30% is the risk of mortality when these drugs are used. And for all the audience, remember there are certain patients who are more vulnerable for these side effects. And I've shown you pictorially. So someone who is elderly, someone who has an underlying lung disease, someone who is a smoker, they become more vulnerable for side effects of these drugs. And please remember the differential diagnosis in ICU for anyone who comes with hypoxemia with CLE. So veno-occlusive disease, lymphangitis, tumor progression, checkpoint inhibitor pneumonitis, and LE stands for pulmonary edema, pulmonary hemorrhage, and lymphangitis. So remember these differentials, rule them out before you make a diagnosis of checkpoint inhibitor pneumonitis. So thank you one and all. So we'll end with this beautiful quote. The true measure of a man is how we treat someone who can do him absolutely no good. So thank you one and all. You can visit my website www.drpradeeprangappa.com to rehear to this lecture.